invited me once again to this meeting. It's always a pleasure and advantage to present something in this meeting. So the ASVAL method is nowadays well known and accepted as an option of treatment for viruses in the vascular community. We have a large experience of 10 years in daily practice after the performance of more than 5,000 procedures. There is several original contributions and chapters of books which have been published, and numerous oral presentations which have been done. There's an increasing number of vascular specialists who perform it. Therefore, what are the lessons that we have learned and what are the perspectives for the ASVAL approach nowadays? First of all, a brief reminder about the basic principles on the ASVAL approach. You may know that the ASVAL method is based on the ascending evolution concept of the varicose disease, describing an evolution from the tributaries up to the saphenous vein, and allowing to limit the treatment to the varicose tributaries in order to improve the saphenous hemodynamics and the clinical status. It's very important to understand that in this concept, the varicose veins, which are called the varicose reservoir, are at the origin of the hemodynamic trouble and not the opposite. This varicose reservoir is treated surgically with tumescence, under tumescence local anesthesia, with a very minimally-invasive surgical approach using atraumatic phlebectomy through microincision, and guided by a very precise pre-op ultrasound skin mapping, as Sylvain Chastanet has shown this morning. What are the available publications about the ASVAL method? The first publication was done in French in 2005 with very short follow-up, 7 months. And we have published the results of the same cohort 4 years later in the journal Vascular Surgery in 2009 with 4 years of follow-up. Actually, we observed that the cohort operated on with ASVAL was younger, more frequently female, with a lower BMI, with more frequent, non-complicated, less extended and asymptomatic varicose veins, and with less important saphenous damage. It was obvious that we have reserved the ASVAL approach for the selected patient with the less evolved stage of the varicose disease. We have also evaluated the volume of the varicose reservoir, which was very new, through the number of zones treated, thanks to this kind of mapping that we use in daily practice. All of the surgical procedures have been done in this paper following the principle that we have previously seen. We have observed a significant hemodynamic and clinical improvement after the phlebectomies, with a complete abolition of the saphenous reflux in 70% of the cases, and a symptom improvement in 80% of the cases until the 4th year of follow-up. We also observed a significant reduction of the diameter of the junction at 6 months, in average 25%, and the importance of this reduction of the diameter was correlated to the importance of the reduction of the reflux in the saphenous vein. The varicose vein recurrence frequency was at 88.5% at 4 years, with in the majority of the cases the absence of a recurrent saphenous reflux, probably thanks to a very close follow-up in the study of the patients. One of the most important conclusions of this paper was that the extent of the varicose reservoir ablation was the key factor determining the hemodynamic and the clinical efficacy, and we found a linear trend between the extent of the varicose reservoir and the clinical results. When the number of zones treated was above 7, an abolition of the saphenous reflux was close to 7 times more likely obtained, and the symptom relief was close to 3 times more likely achieved. We have also presented a study about the influence of the preservation of the saphenous vein in nulliparous patients. We have compared 2 consecutive cohorts of young nulliparous patients, were done primarily in our center, and who had recurrence during the follow-up. We observed that the group who had primary eye ligation and stripping before pregnancy had more complex and more symptomatic recurrence after pregnancy, and therefore we have concluded that phlebectomy with preservation of the saphenous vein may reduce the complexity, signs and symptoms in the event of varicose vein recurrence after a pregnancy. In order to evaluate the risk factor of recurrence after ASVAL, we have conducted a large retrospective study reviewing more than 1,000 limbs operated by ASVAL with a mean follow-up of 36 months. Varicose vein recurrence, a clinical varicose vein recurrence, was observed in 90 cases, and we observed that in a group free of recurrences, the reflux, the preoperative reflux, was most frequently located or limited above the knee, while it was more frequently extended above plus below the knee or at the whole GSV in the group who had recurrences after ASVAL. And in addition, the pre-op origin of varicose veins was more frequently located at the thigh or at the upper calf, while it was more frequently scattered along the calf in the group who has presented recurrence after the ASVAL. In the chapter of the book of John Bergen in 2008, we have presented this comparison from the literature of outcomes between ASVAL, radiofrequency and surgery, and we have observed that the results was at least similar between these 3 approaches for the persistence of